Hey, welcome to Spine Conference. Today's discussion is going to be ipsilateral non-instrumented fusion using BMP and unilateral laminectomy bilateral decompression for instability and stenosis. So I know there's a lot of words, but I'm going to explain all of them. But this is a technique that I've done 7 times, and I use it for cases where it's an elderly person that needs a decompression infusion, but I feel um, a standard technique, it would be too much surgery for them. So I'll explain this to you. So this is not the patient, of course, but looks very similar to that. So I like case-based approach. So we're going to go over this case. And this is a real case. 84-year-old woman with left sciatica. So she had symptoms 45 months, pains in the left buttock, posterior thigh, anterior leg, lateral leg. No symptoms on the right. She's had the pain for a while. She cannot ambulate. Although she's 84, she's an extremely active, vibrant, intelligent person who wants to continue walking. So this is a worsening problem in our society that we're getting older, and like when I become 60, which is going to be when I become 65, I think, which is going to be like in 14 years, there's going to be a lot of people like me. Like there's a lot of people like my age in our society. So our society is getting very old. So this is an ongoing problem, is that we have a lot of old people, and a lot of them are healthy and they want to keep doing stuff. Um, so like 50 years ago, if you're 84, most people didn't live to be the age of 84, and those who did were not that active usually. But now I think our society is getting older and healthier. So it's a more common problem. So otherwise, pretty healthy, total hip replacement, and pretty normal exam. And the X-rays I'll show you the X-rays. So this is a AP view and a lateral view. And Aaron, what are your findings on the X-ray? I just asked you because I want to make sure you're awake.
I'm awake. L4, L5, spondylolisthesis,
Mhm.
L5, L1,
Yeah, so 2 levels of spondylolisthesis. On the AP view, pretty straight. Anything that you can ascertain from the AP view there? No scoliosis, right?
No scoliosis.
And what I note is see that increased, show everyone the increased sclerosis about the facets. You can see that. So the architecture is abnormal there. It's usually due to hypertrophy when you can see that on the AP view. So these are the flexion extension views, and you can see on the right the spondylolisthesis worsens. So that's a problem when the bones slide like that. So the MRI show, just again, you can see the 2 levels, show everybody the 2 levels of spondylolisthesis where the bones are sliding. And you can see on the sagittal cut the bulging discs. Yeah, thank you. And show everyone the ligamentum flavum. So that's the ligamentum flavum from the sagittal cut. And again, this is a parasagittal cut off the midline, and you can see the ligamentum flavum there, that black line. And you can see that compresses, it's a posterior structure that compresses into the nerves. And you can see the spondylolisthesis where the bones are sliding. So here's an axial cut. Show this central spinal canal. That's at L1, L2. So the spinal canal should optimally be the same going down the spine. Here's at L2, L3. It's slightly smaller spinal canal. L3, L4, definitely smaller, and some hypertrophy of the ligament flavum on the lateral gutters. You see that? That's compressing the nerve roots. At L4, L5, you see the hypertrophy of the ligament flavum, trefoil spinal canal. It's in the shape of a triangle. And the facets are very irregular. You see, yeah. Let me show you a normal facet. To show see the facet. The facet kind of looks like a hamburger. That's my favorite thing to eat when we go out is hamburger. See how it kind of looks like a hamburger, the shape of it. I don't know how else to describe it. But then if you look at L4 or 5, it looks like that hamburger was run over by a car, or a truck or something. See how it's flattened, huh? And there's cheese. There's a really big piece of cheese in the middle. So what's that big piece of cheese in the middle? What does that signify? Fluid. So it's fluid in the in the space of the facet. And the reason why there's fluid is the patient in the scanner is laying down. And when the patient lays down in the scanner, the spondylolisthesis reduces. And when it reduces, there's a gap there, and the gap fills up with fluid, and it shows up like that. When the patient stands up, the spine slides. Does that make sense to you guys? I should have drawn it out, but that's what you're seeing. So when you see on an MRI scan on the axial cut, when you see fluid within the facet, that's a sign of dynamic spondylolisthesis. So that's something I didn't learn in residency. That we figured it out from looking at a million MRIs. Like me and my partners figured that out when we looked at a million MRIs in the early 2000s, and that now it's a known sign called the fluid-filled facet sign. Axial cut L5S1. Centrally, the spinal canal is big, but on the left, because she has sciatica, you see that hypertrophic ligament flavum. That could be compressing the S1 nerve root. Show everyone the S1 nerve root, Aaron. Where is it? Nope. I got you. Which one is it? That's L5 going out there.
Oh.
Where's S1? Remember I say here, look at S1, Aaron, when we were in surgery. I'll say S1 is this thing. That's S1. You see S1's?
Yeah, it's gonna drop.
S1 is being compressed by the disc in the front and ligament flavum in the back. It's not really that compressed, but the area is tight. But you can imagine if someone stands, that nerve can be hit. So any questions so far? So 84-year-old woman, left sciatica. What do you think we should do? She wants surgery. She wants to be fixed.
Well, we absolutely have to decompress.
So we can decompress her. The problem I have with decompressing somebody is that I will create instability.
More instability.
Yeah, and then so if you decompress, patient feels great, but then comes back 3 months later with instability and failure. It's a problem. And the reason, like, well, why can't you just do a fusion? There's a couple of reasons in my mind. One is patients are emotionally upset. To get up for a surgery, it takes a lot of strength. You know, like I'm doing this, I'm doing surgery. Everyone's worried grandmom's going to die. Patient's concerned they're going to die. They're old. They don't want to have to do that twice. The second thing is problem is it's hard to do revisions. Like, you know, when we do revisions, there's a lot of scar. It's more difficult surgery. So there's more risks of nerve injury. There's more risk of spinal fluid leak. So it's best not to have to go back, obviously, but you also don't want to do unnecessary surgery. So that's the question on mine. So you could, I don't know, what other options? Anybody have any other options we could do, surgical options? Brian, you have any new techniques that are okay? Not for 84-year-olds. So the inserting pedicle screws takes time, muscle trauma because you have to put the screws in. Those need bone, yeah, good bone quality sometimes, but usually that's not too big of a problem. But it's not that big of a problem. The biggest problem is time and muscle dissection, and it's just more surgery for patients. So this is what I did for this patient. I did a unilateral laminectomy, bilateral decompression at L3, L4, L4, L5, L5, S1. And then the two areas that had spondylolisthesis, I fused it posterior laterally using bone morphogenic protein, BMP infused, and mastergraft on just that one side. So this whole thing was just a unilateral approach. I just opened the spine on one side through basically a hole, like a hole on that one side. And no instrumentation. And here she is, I think like 3 months post-op. Aaron showed that big wad of bone. Yeah, see that big wad of bone has fused. It's only on one side, but if you get one side to fuse, that should be enough to stop the spondylolisthesis and never have a problem again. And you can see the lateral view, spondylolisthesis. And clinically, this patient did incredible. I mean, she was pain-free, walking. She can go to the store now. She can visit her friends. It was a home run. So any questions? Yeah. I don't put braces on people. I don't think it works. It works on skinny children. In adults, it doesn't work. So you get a thin child, you can put that child in a brace and it'll work. But adults, they don't, especially over 70, people do not tolerate braces. They don't want them. They don't understand them. They're uncomfortable. It doesn't work. Especially if they have a big body, the braces don't even work because there's just too much fat and soft tissue between the outside the skin to the bone. So it doesn't work very well. Okay, so I just want to go over a couple more things. I want to go over the unilateral laminectomy decompression. So Crystal's eye there is in the spinal canal, and if you could look down the center of the spine, there's a canal where the nerves run. Thanks, Aaron. And at each level, the spine's made up of multiple bones stacked one on top of the other, and at each level there's a foramen or a hole where the nerve exits. You can see my pen there is in the foramen at L4, L5. So normally the spinal canal, that's a sagittal cut MRI. Normally the spinal canal is the same all the way down. So that's a normal MRI. So here's essentially the spinal canal. Show the air essentially at L5S1. This is a normal MRI. L405 same size. L304 same size. This guy has a femoral disc, but look at essentially. L203 same size. L102 same size. T12L1 same size. So that's what T12. So that's what it should be normally. But some patients are not like that. Some people have a developmentally small spinal canal at L3, L4, L5. They're just born like that, or they develop like that. But that's what it should look like. So this, again, the spinal canal is the hole in the center of the spine where the nerves run. And I won't get into that. So this is a cut through a dead person, a young dead person, through L5. And the point of this is you can see posteriorly, Aaron, show the musculature. Those are the recti spinae muscles. And when you spread those things apart to do a standard laminectomy or fusion, you cause a lot of muscle damage. Just imagine the standard technique, the old school spine surgeons would put that crank in and crank that sucker all the way so you can see all the TPs and show the end of the TP. So if you can see that end of that TP, those muscles are totally compressed. I mean, like really damaged. So that goes to show you if you do the standard technique for exposure for a spinal fusion, you really damage the posterior musculature. Does that make sense? Huh? Yeah, that too. So I don't know why I showed this. So the standard technique is for decompression is a laminectomy. You cut on either side of the spinal canal and you completely remove the posterior spinous process. So here's another view of it. You totally remove that posterior spinous process. That's a full laminectomy. The problem with that is it removes the muscular attachment to the posterior spinal elements of the spine, and the bones have a tendency to slide afterwards. This is another technique called a porthole decompression, which was taught to me by Chuck Edwards, my former partner, the first image. And the image on the right is the person who wrote this article, who was this fellow, about how to do a decompression porthole without doing a laminectomy, by just drilling a hole centrally, what the neurosurgeons call interlaminar space, where the two lamina come together. That's where all the stenosis is present. So you don't need to remove the posterior spinous process to fully decompress. So this is another way to look at it. On the right is a full laminectomy, and the darkened area is what you remove. So that whole posterior spinal process is gone. Down is the porthole technique, and the posterior spinous process is kept intact. And on the left is a unilateral laminectomy bilateral decompression, where everything on the one side is normal, and you just make a hole on one side. So it cuts down the muscular dissection and trauma by half. So I won't get into it, but this is just an article from 2014, a randomized trial of unilateral laminectomy bilateral decompression or ULBD versus open laminectomy. And the patients who had the minimally invasive approach did better, 79 patients. And the dark one is the open laminectomy, and the gray one's the minimally invasive approach. And just everything, like length of stay was lower, they got mobilized quicker, and they had fewer opiate use. This just shows you a sad axial cut of what the decompression looks like on the left, how you could open up the spinal canal from just one approach. Usually the biggest offending structures are the ligamentum flavum and also the hypertrophic capsule and the facet. So I'm not going to get into this. It's just this is a nice image of how you do it. You can see you go on the left as you go down on one side, fully decompress the spinal canal, and then you tilt the microscope in the table, you can get the other side. And now that the microscopes and the drill has gotten so much better, you can do this. Like you couldn't do this 15 years ago. It's just these are just some more things. So what are the pitfalls for this approach? The pitfalls are I've had cases of restenosis, so the other side gets stenotic, so you do it from a left approach, the right side gets stenotic, and I've had to go back and open up the right side, which is not a big deal. You can get the other standard injuries from any laminectomy. So any questions about unilateral laminectomy, bilateral decompression? Okay, so I just want to go over BMP now, and then we'll be done. So bone morphogenic or BMP is recombinant DNA. It's made by Infuse is made by Medtronic, which is domiciled in Ireland. It used to be Minnesota, but they moved the corporate headquarters to Ireland for tax reasons. It's a recombinant DNA that you put on a collagen sponge. So it's an absorbable collagen sponge that I just looked it up today. It's made out of the flexor Achilles tendon of cows, type 1 collagen. It's kind of interesting. It's absorbable. And then on top of it are these granules, the master graft or calcium hydroxyapatite granules. And this is when the granules are separate. Now I'll show you a newer product. This is from yesterday's case. This is how I do it. Is I put the BMP sponges on either side like an ice cream sandwich, and then the master graft comes in a cake sort of. So it just makes it a lot cleaner and easier to handle. And this is on the back table, the two sponges with the master graft. We just put them together like an ice cream sandwich. Why do I do that approach? I just like ice cream sandwiches. That's why I do that. So the density is 1.5 milligrams per cc. And this was on the first paragraph is what goes into the BMP. There's like sucrose, glycine, etc. And just the ACS is the absorbable collagen sponge, and what it's made up of, the deep flexor Achilles tendon of a bovine, of a cow. So that's easily absorbed. So what can we use for bone graft? We can use iliac crest is what I usually use, and that's the gold standard for fusions, and it works extraordinarily well. You can use local bone grafts, not as good. Allograft's not as good. BMP, demineralized bone matrix, which really doesn't have BMP in it, and it just has the allograft and ceramics. An iliac crest, usually I take it from the posterior iliac crest. I cut the top of the bone off, and then I get everything from the middle out, but I basically hollow out the ilium. But all the muscles, everything's are kept intact, and then I fill it back up with cancellous allograft cubes, and in a year that thing is normal. And we've gone back a year later, and it's like a normal crest. It's remarkable, right? Don't you like them? That was amazing. Yeah, how normal it is. You can use allograft for fusions. It's not as good though because it doesn't have BMP and it doesn't have cells. That's the problem with allograft. It's just a structure. So to fuse it, you need three things for bone formation. On the left, you need axial conduction, which is a scaffold for the bone to grow into. That you get from allograft or DBM. You need osteoinduction factors on the top. That's the hormone or bone morphogenic protein. And you also, on the left, you need cells. And the cells come from the patient. They can come from the iliac crest. They can come from the patient themselves too, from the muscles or from the bone that you drill out. So you need all three of these things to get a fusion. So BMP was discovered by Marshall Urist at UCLA. He described it in 1965 in Science, and it was FDA approved in 2002 only for one use, interlumbar interbody fusions using this cage, which nobody does anymore. 85% of the use of bone morphogenic is off-label, so almost nobody. It's rare for people to use it for its FDA-approved use. It was also approved, I think, in 2010 for revision posterior fusions for non-unions and smokers, patients that are high risk. Also, it was approved in 2004 for acute open tibia fractures treated with iron nails, made by Medtronic. So what problems are there with BMP? Sounds great, right? You don't have to use iliac crest. Problem one is it costs a lot of money, somewhere between $1,500 to $5,000, depending on how big you use. Like a medium kit's what? Like, do you know? That,
Not off the top of my head, I can get
a medium kit's like $3,500, and it's a lot of money. It's a lot of money for the hospital to shell out. Okay, these are all complications that I've had with bone morphogenetic protein. This is a 45-year-old woman who presented 1 year after her surgery with a wound infection after having had a fusion. And they got a CAT scan, and the fusion is solid, rock solid. You can see the bridging, showing the bridging bone on the coronal cut on the left, Aaron. See, that's bridging bone. But you saw a fused L4, L5. Look at L3, L4. L3, L4 fused too. And you can see on all the views, L3, L4 is solidly fused. And I didn't try to fuse L3, L4. That's basically ectopic bone formation. It kind of fused, overdid the fusion. Other things it can do in A-lifts. This is an anterior lumbar interbody fusion, which I rarely perform. But just so you know, that's an A-lift. In A-lifts in men, it can cause retrograde ejaculation. So on this slide explains the mechanics of ejaculation, but basically the sperm, instead of going out where you want it to go to get pregnant, it goes into the bladder, which, you know, I guess nobody cares about unless you want to have children. If you want children, it's a really big problem. So this is, and the incidence is like just a couple percentage points, 2 or 3%, but still, you know, most guys don't want that unless they're done their children, I guess. Huh? You can joke, make jokes, of course. So for ACDFs, a lot of people use allograft, so that's an option. So what happens if you put BMP, a lot of BMP into the neck? I've had this complication myself. We used to put a large dose of BMP into the neck, and they would fuse extremely well. But some patients will get this terrific swelling of their neck. So Aaron, show on the lateral view on the right, the distance between the plate and the trachea. You see that? That distance is probably about 35 millimeters there, and it should be like 5 millimeters. So people were getting this terrific swelling of the neck, and we admitted a couple patients to the ICU because we thought they would lose their airway and die. Nobody died in our hands. We stopped the use of BMP, but this was like a serious problem, so we stopped using BMP in the neck because of the swelling. And there's another view. Aaron, can you show the trachea? There's the trachea, and it's like really displaced from right behind it is all this terrific amount of soft tissue swelling. So if you put BMP in the neck, it causes terrific amount of soft tissue swelling, and patients can lose their airway. The response is you can say, well, you don't use BMP, or the other option is you just use a very, very small dose, like less than 0.5 cc's, half a cc of BMP. If you use a dose of half a cc of BMP in the neck, people don't get these complications, and they fuse. So that's the learning point for in the neck. In my experience, it was within a week. So it's usually like post-op day 5. Other things is you can get a terrific amount of, you can get a postoperative seroma. This is a case that I did, and she presented with actually back pain, and her back was really swollen, and she had this very large seroma. That's just one cut, but it was really, really big, and I had to decompress it. I took her back to the OR and just opened it. This is another guy who had a seroma post-op day 8. You can see the back of the neck, the huge seroma that he has. All filled with fluid, and it was like tense, and I just opened it at the bedside. I was just curious what would happen if I put a knife to it, and the fluid just came out like a geyser. It was terrific. And then after that, he goes, I feel fine. So I didn't take him to the OR, I just opened it at the bedside. A terrific amount of fluid. As a posterior. Here's just another case of another huge seroma in the back. And you can see how big the seroma was in the soft tissues. And I opened her up at the bedside too. But then they weren't infected. They did well. I've had about 5 of those seromas when I used to use BMP regularly. This is another interesting case of psoas calcification. So, Aaron, show the TP. The transverse process is where we put the BMP, the bone graft, and just in front of that, anterior to it, is the psoas muscle. So the psoas muscle is what gives us hip flexion. We lift our hip up when we like get into a car. We lift our hip up. You can calcify the psoas muscle from BMP because it's right next to where the BMP is. So this is a case of mine, 77-year-old woman who was happy, who had low back pain, buttock pain, had some lateral recess stenosis, and this showed them the psoas, Aaron, on the left. Can you see that big muscle? I'll show you. This is the psoas, and it's right here's the TP right there. It's just that's another cut. It's just in front of the transverse process. So she had this really bad leg pain. Her X-rays were normal, but then when I got a CAT scan, I was worried that maybe the screw was hitting a nerve. The left psoas has calcium in it. Show them the left psoas, Aaron, on the left, other side. That's it. See that white stuff in the middle of that bone, of that muscle? And see how that muscle's bigger than the other side? So it's all inflamed and calcified. And then here's on the MRI, you can see it's heterogeneous. It looks like heterotopic ossification inside the psoas. So basically, the psoas muscle was turning the bone. The other interesting thing on this MRI is show the iliac crest. You can see where I put the bone graft on the other side. See where I put the bone graft in the iliac crest that reconstituted it. So that patient, eventually the pain went away somehow. So I guess the inflammatory part got better and it didn't hurt. It was calcified, but it just wasn't painful. But it was painful while it was turning into bone. It was inflamed. Another problem with bone morphogenic protein is ectopic bone formation. So bone grows where you don't want it to grow. So this is the most common problem when you do PLIFs and T-lifts, which I don't do a lot of. But if you put the BMP in the cage, interbody device, and push it in, that's the most common way to get ectopic bone formation near the nerves. So they say that to stop that, you bury it 3 millimeters deep and you cover it with Duraseal. Do you do that, Brian? Or do you, that's what people say will stop the ectopic bone formation. So this is a case of a 66-year-old woman, left sciatica. She had L3, L5, posterior decompression, L4, L5 fusion, did well, but then had recurrent sciatica 3 years later. A repeat MRI scan shows dramatic overgrowth of bone. So you can hear this is where I did the decompression fusion. The bone on the bottom right, the bone overgrew into the spinal canal. It shouldn't grow. Once you fuse, it should stop growing. Another problem you can have is osteolysis. So when you put interbody devices, instead of the thing fusing, the osteoclasts haven't absorbed the bone and erode the bone. So it's the opposite that you want. Another problem is radiculitis. So if you put the bone morphogenic protein near the nerves get extremely inflamed and cause severe pain, but usually it goes away. It's transient for just 2 weeks. Another problem with bone morphogenic protein is that, hey, I'm good. Okay. Another problem with bone morphogenic protein is it's a growth hormone, so it can stimulate cancer cells. So if a patient has cancer, especially active cancer, it's contraindicated. I basically never use it in a patient with cancer, just because I'm worried that it will activate their cancer, because it's a growth hormone. So the dosage for bone morphogenic protein, again in the neck, ACDF is very, very low, 0.2 to 0.6 milligrams per level. And posterior lateral fusions, around 8 to 12 milligrams per level. And so it's 1.5 mg per cc, so that's like a medium kit per level. And less than 4.2 mg per level for T-lifts and for A-lifts, dosage-wise. And that's from a review article recently that I emailed you guys. Okay, that's it. So any questions today about bone morphogenic protein? Aaron? Everybody? Kirsten? Any questions? So this is just, huh? It's interesting. So it's a technique of the unilateral laminectomy, bilateral decompression, and then BMP for these very elderly people that have stenosis and a deformity. Unfortunately for Brian, I'm not using the screws, but this is it's an option. Hmm.
He's clearly has a very high lipid content. That might just looks like Swiss cheese. That's where on radiographically it looks like a huge mass, but it's really more of an show with a high fat content.
That's interesting.
So he's still gathering, but
That's interesting. I mean, I found when I revise cases that have had BMP, it's just a terrific amount of bone.
I think it's early on.
Right. Initially, yeah, but over the years, it just becomes like a big piece of bone. It just remodels. Okay. Any other questions today? All right. Thanks for coming. See you next. See you.